Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back. I'm your host, Hallie Tecco, and today I'm chatting with Dr. Sachin Jain, President and CEO of SCAN, which is on a mission to keep seniors healthy and independent. SCAN is a massive organization with revenues topping over $4 billion, and they are serving over 300,000 patients. Previously, Dr. Jain was president and CEO of CareMore and Aspire Health, innovative care delivery systems. He also pioneered the first clinical program in the world focused on social isolation. Sachin, welcome to the show.
Thank you so much. Great to be here with you, Hallie.
We have so much we're going to cover today, but I want to start off by talking about Medicare Advantage. And for our listeners who are new to healthcare, Medicare Advantage, also known as MA or Medicare Part C, it is a Medicare-approved plan, but it's actually operated by a private company that offers it as kind of an alternative to traditional Medicare. And enrollment has more than doubled since 2010. And actually today, more than half of eligible beneficiaries are actually enrolled in Medicare Advantage. So the government is actually operating fewer plans than we were 10 years ago. Sachin, you guys run an MA plan. What trends are you seeing in this world?
It's a really, really boring time for MA, Hallie. Just kidding. There's so much going on right now. I would say top of everyone's list is the implementation of the new risk model, what people are calling V28, which took a lot of money out of the system in terms of risk adjustment for caring for sick people. And so you're seeing revenues decline in a number of markets where there was a high degree of coding intensity. You're also seeing changes in the STAR system. So it's becoming harder and harder to achieve high STAR ratings. STAR ratings are tied to bonus payments, which are tied to benefits. And so you're starting to see some plans slashing benefits because it's harder to achieve those high STAR ratings. You're also seeing some plans leave markets altogether, pretty dynamic there. And then you're also seeing a slower than historic rate of increase on Medicare base rates. And that's important because over the last decade, Medicare Advantage was seen as probably being a bit more generous than traditional Medicare in terms of payments. And now you're seeing a lot of health systems that were leaning in the direction of Medicare Advantage saying, we want to kind of rebalance our Medicare portfolio to fee-for-service Medicare. And so super dynamic time. You're seeing share prices of the publicly traded companies that are exposed to a lot of MA decline, pretty significantly. This was a darling area in terms of startups for the last decade. Mm-hmm. You're seeing a lot of startups retrench and, rethink their strategies. Then there's the whole MA adjacent ecosystem, the Oak Streets, the ChenMeds, the Landmarks. All of those companies are also, I think, pivoting in the face of a lot of these changes. So super dynamic time. And on top of that, you add Dr. Oz, right? So Dr. Oz is, President Trump's expected nominee for leading the Centers for Medicare and Medicaid Services, cardiac surgeon, talk show host. But one thing he has been very vocal about in the Medicare space is he's very pro Medicare Advantage. And so a lot of us who work in this space are wondering, what comes next? Is this going to be a new golden era of Medicare Advantage? Hard to know. Hard to know.
What could he change that would make it a golden era and kind of bring back some of the downturn that we've seen in MA?
Well, I think there's just some basic plumbing that needs to change. I think CMS at a high level actually needs to recast itself. I worked at CMS earlier in my career, and I would say CMS saw itself as being a claims payment organization. They received claims, fee-for-service claims from doctors and hospitals, and they paid them. And they paid them efficiently, and they paid them well. But now, as to your earlier point, the dominant program is Medicare Advantage. And I would say it needs to shift its self-image away from just a claims payment organization to an organization that regulates competition, across health plans around the country. And that means innovating around how we administer benefits, standardize benefits, thinking about, are we going to build dental and vision and audiology coverage into traditional Medicare, or are we going to lean into the private sector to deliver some of these benefits that Congress has not authorized in traditional Medicare?
Yeah.
Lots to do, honestly.
Yeah. What is the difference between the Medicare Advantage providers who are for-profit versus nonprofit? Are they performing at the same level? And just acknowledging that you run a nonprofit Medicare Advantage plan.
I run both. And I'm not one of these people, just to be clear, I'm not one of these people who thinks for-profit is good or not for-profit is bad and not-for-profit is good. I think there's really good actors and really bad actors across the spectrum. I would say writ large, when you look all across the country, not-for-profit plans have higher star ratings than for-profit plans. I think not-for-profit plans aim towards benefit stability. So, when there are these wide swings that happen, in coding models or star systems or base rates, oftentimes the for-profits will adjust by cutting benefits, or they'll leave markets. They're aiming to deliver a 3 to 5% margin to Wall Street. That's what a good Medicare Advantage margin looks like from an equity research perspective. Now, not-for-profits, when they sustain some of these cuts, our orientation writ large is to try to hold benefits stable. And so, we tend to not be the shiniest products in a marketplace, but we tend to be the most stable products in a marketplace. And I think that beneficiaries tend to appreciate that stability because there isn't that sense of a bait and switch. Oh, I joined when there was this fancy rebate, or there was this pesticide benefit that then 3 years later it gets cut. So
what's a pesticide benefit?
It's a benefit. So, for the last 5 years, you've started to see plans introduce a wide degree of, innovate what are so-called innovative benefits. You had one plan introduce pickleball, rackets and
which
pickleball
actually I
benefits.
love that.
Yeah, and you want seniors to be active, but then some plans articulated the idea that access to pesticide services would be important to people's health, and so actually lobbied CMS to get coverage for pesticides, but then put it behind a utilization management wall that required a doctor's note. So at the end of the day, very few people ended up using those benefits. So the point is that there's been a lot of benefit innovation. Cash rebates are the most popular benefits. You see those advertised on TV, get $50 back or $100 back. And that, of course, refers to your Part B premium, which, last year was $174.90. If a plan offered you a chance to get, half of that back or all of it back, that seems pretty attractive to people. So, again, there's been a lot of
how can traditional Medicare even compete with that?
Yeah, as Rick Gilfillan, one of the most kind of noted critics of Medicare Advantage, has said, if you give people ice cream, they're going to eat it. I think that's true. At the same time, traditional Medicare has some advantages. Traditional Medicare's real advantage is that you have an open network. You can go anywhere. And there's actually no utilization management. Contrary to almost every other health plan that you've been a part of your whole life, there's literally no utilization management. You can get any service you need anytime you want it, any place you want it. You're just going to have to pay a lot for it. And so, I think that traditional Medicare has become a high-income senior program.
Yeah.
And I think that Medicare Advantage has become a middle-income senior or low-income senior program. But the reality is that we need to kind of look at both of these programs and reboot them. I mean, when Lyndon Johnson wrote this into law with Harry Truman as the first beneficiary, they wanted this to be a program that provided people with income security. But medicine has changed, healthcare has changed. Yeah. We have lots of new therapies, very expensive therapies. And unfortunately, it's really hard to be a senior in traditional Medicare today. You're going to spend hundreds of dollars on premiums for Part B, Part D, for a Medicare supplemental policy. And the average income of a senior in 2024 was about $51,250. So, you could spend upwards for a couple of $1,000 a month, on healthcare costs. That's a lot of money. And that's why Medicare Advantage has been a better deal because, there's actually, opposite from traditional Medicare, there's a maximum out-of-pocket cap for most plans. CMS requires you to actually have one. And so you have a high degree of transparency of your out-of-pocket spend right out the gate.
Yeah. So you mentioned the star ratings, and this is something you've actually gone up against, this star rating system of CMS. Tell us, what exactly is the star rating system, and why do you think it's flawed, or why did you think it's flawed?
Look, it's a system that rates all MA plans from one stars to 5 stars. And I think the star ratings program is great. It allows people to, at a high level, just figure out if they're part of a high quality plan or a low quality plan. Where the program has really kind of lost its way a little bit is that very small differences in like single measures on single measures can be like a big swing of literally hundreds of millions of dollars to revenue to plans. And some of these, measures involve judgment calls. I mean, our lawsuit involved 2 things. One was the Tukey outlier methodology, which they introduced last year, which was a new statistical methodology for actually calculating the cut points for each of the individual ratings. Big mouthful there. And then the second thing that our lawsuit was about, a French foreign language phone call, which I wish we could play it on this podcast, but this secret shopper calls, we're supposed to answer their question within 7 minutes. And like there's a bit of jankiness in how they asked their question, and the call ran to 7 minutes and 34 seconds. And 34 seconds of like jankiness, for us was a $250 million question. So we sued both on the outlier methodology, and we also sued on the French phone call. We actually won on the outlier methodology and actually reset star ratings for the whole industry last year.
Wow.
This year, what's happening is that many people are now kind of looking at the fact that we were able to contest this, single phone call, and they're looking at their own phone calls and saying, there's hundreds of millions of dollars at stake here. And by the way, these dollars don't all drop to the bottom line of plans. They go to providers in the form of higher payments, and they go to beneficiaries in the form of better benefits. And so, there's a lot at stake for a lot of people with just these like small number of metrics. I think, if I were advising Dr. Oz, I'd say like you need a star rating system that's a bit more robust, where there's a bit more statistical significance, where a single phone call doesn't necessarily swing things this way or that way. I actually think you have to get off of like the Cliff Vest view of the world, which is like these huge gradations between 3.5 and 4, and instead maybe make it more continuous instead of discrete. That's kind of how, what I would suggest to this new administration.
Great. I'll pass on the message.
Please do. Please do. So.
What other things do you think this administration should keep in mind when it comes to healthcare?
Well, I think one of the failures of the value-based care movement over the last several years was really measuring value in 1-year increments. And I would say there's nothing magical about 365 days. And healthcare value is actually produced in much longer timeframes than I think most people acknowledge. It's really produced in 3, 5, 10, 15, 20 years. And I think one of the biggest challenges we have in healthcare is annual enrollment. And we have to kind of, and this is a big problem for digital health, a subject that I know you spend a lot of time thinking about. If a company has to improve outcomes in a year, they focus on the simple procedural things or the regulatory things, and they don't really focus on outcomes because they have, they sign a contract, they have 6 or 8 months to prove that they bent MLR. And so they focus more on maybe revenue capture than they do on cost management or outcomes improvement. So I think getting the world to think more long-term, and in his kind of non-typical, non-traditional ways, maybe RFK Jr. can get people to think more long-term instead of thinking short-term.
Yeah. How do you do that, though, with health plans that will continue to only cover, if we continue with our employment-based health insurance model, where people stay in jobs for 2 to 4 years on average? How can we ever combat that?
I think health plans I think there's an opportunity to re-architect the American health plan. And maybe it's employers are providing a defined benefit. And maybe that defined benefit allows for portability.
Yeah.
And that portability allows people to stay on a plan for 3 or 4 or 5 years. And I'll tell you, the benefits that people would invest in would shift more towards intensive outpatient management of chronic disease and probably prevention of chronic disease.
And GLP-1s would be covered.
Exactly. The kinds of things that we know bend outcomes would be covered more. Instead, right now, people who literally have the secret sauce can't get it paid for because it's all paid for in 1-year increments with 1-year ROI periods. So we have a real, I think, deficit in terms of how we think about investing in health. We don't have a long-term investment period.
Yeah. Yeah. I've heard it said, everybody just is passing the buck to Medicare. And, by then it's
that's
too
exactly
late.
right. When people become, SCAN health plan members, they come to us with all their chronic diseases. They come to us with a lifetime of, bad habits. And then we suddenly give them silver sneakers, gym membership, and say, now go to the gym, when they've spent 40 years not going to the gym. So I think that there's a lot of opportunities for us to, think differently about healthcare if we take a fresh view of things, if we're willing to disrupt the orthodoxy. I think the real problem, the real crisis that we've had in American healthcare is one of leadership. We're largely governed by incrementalist politician leaders instead of folks who really want to lead real change. And I think anyone who's ever tried to change the US healthcare system and saw the gap between the words on the wall and almost every healthcare organization in the country and then the actions of that organization knows that that's really the problem.
Yeah. So you mentioned kind of SCAN. Now would be a great time to share with our listeners what you guys do. And if you can tell us just a little bit about the origin story. I've heard you say it was started by 12 angry seniors. So I want to know who they are and
so
how
first
you
I want
ended
to
up.
clarify, we're not a radiology company. SCAN is maybe the worst acronym ever. I love the actual underlying words, which is Senior Care Action Network. And we were founded by a group of people we affectionately call the 12 Angry Seniors. This is a group of people who were tired of the status quo, did not want to go to a nursing home in their final years, wanted to age in place, wanted to build a set of services. And what is old is new and what is new is old. They were focused on things like the social determinants of health. They were focused on transportation. They were focused on food. They were focused on how do we get the things that we need to be able to age gracefully at home. And then, like most great ideas in American healthcare, it got socialized into the system that we had. And I think they had a great vehicle for a number of years, which is they were part of the social HMO demonstration project, which was an attempt to integrate social services and healthcare services and use it to lower total cost of care. SCAN was the oldest and longest running of the social HMO demonstration projects.
In the 90s?
And then over time,
when was this?
In the 80s and 90s,
Amazing.
yeah. And then we became a Medicare Advantage plan. But I would say the last 5 years, we've been on a journey really back to the future, which is to go back to our origin story. It's why we executed this big rebrand, really focusing on the 12 Angry Seniors. It's why we've focused on expansion. It's why we're focused now on, we've launched 4 new clinical care delivery divisions that actually provide services to people in the home or in the community where they live. So it's been an exciting few years. Yeah.
Well, let's talk about home health. It seems like home health can drive cost savings, but some of the evidence is mixed in terms of outcomes. What is kind of your take there? Why are you going more towards home health?
Well, I think there's a segment of the population for whom home health care is the right model of care, right? And, home health care is a lot of different things. It's hospital at home, it's home-based primary care, it's home health in the traditional sense of that term. We believe that seniors who have multiple activities of daily living needs shouldn't be burdened of having to take 2 buses to get to a doctor's office for a 10-minute visit that they could have completed virtually. Yeah. And we also believe that the home environment really influences people's health outcomes. And so at Welcome Health, which is our primary care medical group, we provide care in offices and virtually, but we also provide a significant number of home visits for people who need them. For people who have chronic diseases, we have an entity called Home-Based Medical that actually provides home-based visits, does deep assessments of people's needs, and tries to manage their chronic diseases as well as take care of them after they've been discharged from the hospital. We have Healthcare in Action, which is our medical group for people experiencing homelessness. That people's homes in that case are literally the streets. And so we're going to them, actively finding them, staying close and connected to them and trying to care for them. And so, that's the kind of work that we're doing right now that I think is really in line with the spirit of the rebellious spirit of the 12 Angry Seniors.
Yeah. I mean, I would rather have a provider come to me in my own home. That feels like a luxury to me.
Yeah, I would say a lot of people don't want that actually, because, they either don't necessarily want somebody at their home, or they feel a little bit self-conscious about where they live. You have to remember, a lot of people wear their, Sunday best to the doctor's office. And so, having someone come to their home doesn't always feel good to them.
Yeah.
That said, I think if you actually genuinely needed it, I think it's the right model of care. But it's hard to deliver efficiently at scale. I mean, there's real execution challenges with this in terms of just geography as vast as Southern California. I have to remind people is like, it's, nobody ever drives 60 minutes to go from Boston to Providence. When I lived in that city, like never happened. But here in Southern California, people routinely drive an hour to get from A to Z.
Yeah.
And so there's a lot of inefficiency in windshield time if you're delivering a lot of care at home.
Yeah, I know you guys started in SoCal. How did you decide what states to expand to, and like what are the overlaps among them, and like what do you do to kind of tailor to the different geographies?
Yeah, so SCAN grew up in the fully delegated model. So what that is that the medical groups, rather than the health plans, own the risk, and they actually administer the networks, and they do their own utilization management. And so we're set up really well to administer full delegation of risk to provider groups that actually are able to take it. And so those groups predominantly exist in Arizona, Nevada, New Mexico, Texas, the Southwest, where these models are pretty mature. Over the last 2 years, we've actually moved out of full delegation of risk and are now contracting with groups where they're not necessarily paying their own claims or contracting their own networks, but they are willing to take financial risk. And so that's potentially pushing us outside of the Southwest. We have national aspirations and ambitions. We think that there's a lot of opportunity to do MA better and differently. We think that there's been a historic amount of tension between plans and providers. We think that there's opportunities for deep collaboration, almost virtual integration with provider groups. And so that's the work we're trying to do.
Well, and there may be more of a trust between a nonprofit like SCAN and a nonprofit hospital system. There's like you're related in a way.
Certainly. Yeah, you might be. It sounds like you're sitting in on some of our business development meetings.
So you still see patients as a VA hospitalist. Correct me if I'm wrong.
I do. It's very occasionally at this point.
Yeah.
I mean, what I'm hoping to do actually is over time kind of switch my practice more towards our institutional special needs plan, SCAN Embrace, where we actually provide care to people in nursing homes in their last few years of life. So that's kind of where I'd like to take my clinical practice, but historically,
like the CEO is here to see you.
Well, I probably wouldn't announce myself that way, but yeah. So.
I'm sure someone else in the room would. Yeah. And you've held a bunch of different roles across government, industry, and academia. Like, in which areas do you think that these players are aligned, and where do they disagree?
Well, I think, look, I've actually been in pharma too. So the thing is that what I've now seen consistently is everyone names a boogeyman and blames some other sector for their problems. And so if you're in a health plan, you're blaming pharma companies. If you're in a pharma company, you're blaming regulators. If you're a regulator, you're blaming health systems. There's just this cycle of shame and blame that Brian Powers and I wrote about years ago in JAMA. And I think it's at the source of our failure to develop multi-sector solutions to problems, is that it's far easier to blame other sectors than to look inwardly and try to address your own problems. I think, what we are sorely missing is like a view to the bigger picture. I mean, when I say we really need a leadership revolution in healthcare, we need a group of people across sectors who are willing to sacrifice kind of short-term sector-oriented gains for like a bigger picture. And I think these people exist. I think there are people who are like students in your class at Columbia, Hallie, like young people come up with the absolute right ideas, and then we beat them out of them. And like we teach them that they need to be incrementalist, and we teach them that they need to like think small and not big, and we teach them that they have to work within the system and instead of like reinvent the system. And so
we scare them away. We scare them away from healthcare.
Totally. Yeah. Or we just get, we get them reoriented from like fixing the healthcare system to like, paying for their kids' college tuition and graduate school.
Extracting value for themselves. Yeah.
Exactly. And so, the big reset that needs to happen, I think, is that we have to define our current state a little bit more granularly. Instead of saying like, oh, like we've got great healthcare, or our system's doing a great job, or our health plan's doing a great job. I routinely tell people at SCAN, I'm like, we're better than most, but we're far from great. I mean, that's the truth. Like, that's the real state of who we are. And because I think that there's a degree of toxic positivity in US healthcare where it's like companies that are coding companies are calling themselves value-based care companies. And frankly, 95% of value-based care companies are basically that. They're not fundamentally changing the contours of what care looks like for vulnerable people and patients. And I think if we start calling BS a little bit more, I think we will have a better shot at actually solving the my current thesis. I don't know.
I feel like lately there's been a lot of BS calling lately. But so I'm curious if there are organizations.
Which BS calling? Tell me.
I feel like health plans and the big five and their vertical integration is certainly under the heat right now. Value-based care companies are absolutely. Medicare Advantage. I kind of feel like it's a negative time. We're like looking at all these things that we were very optimistic about. And, the pendulum always swings. It's like, oh, we're excited and value-based care is the way. And then, oh, actually, maybe it's not as perfect as we thought.
But I don't think most of the people who kind of talk about value-based care would define it in the same way. I think, they would do some like really shallow Michael Porter quality over cost kind of conversation. And it gets stuck at that. And, I've been thinking that we need a new definition of value-based care, like intensive outpatient care of patients to, prevent disease and manage disease in the most cost efficient way or something like that. That's a little bit more granular, that actually talks about what we're really talking about, as opposed to what I think has happened, which is we're like quality over cost. And then people start playing the MLR game, which oftentimes, means juking the revenue stats. I mean, I think The Wire tells you everything. I don't know if you're a Wire fan, Hallie, but like, you should watch it.
Okay.
Seasons 1 through 5. Like,
good. I need something new to binge.
If you can get through episode 1, which is like kind of a janky episode, you'll fall in love with it.
All right. Noted.
But like you'll see so many parallels to healthcare. We're like not really focused on real impact. We're focused on headline impact.
Yeah.
And again, I think that there's
vanity metrics for sure.
Yes. Yeah. This is a sociological problem as much as it is. Anything else.
And I think, as you said, like there's been some concern around just the word value in value-based care. And I know like Intermountain Health, for example, they have started to call it proactive care versus value-based care because they're finding that people think that value is like cheap. It's like
cheaper.
Going to Walmart.
For sure.
Versus what it is. So I agree. I mean, it's probably worth, doing some good market research and coming up with a better way to brand and define this concept of paying for outcomes and aligning. I mean, the idea of just aligning folks with better outcomes makes a whole lot of sense. I think it just gets tricky when you're like, okay, how do we actually implement this? And who's actually willing to take on this risk?
Another thing I hope to see from this next administration is real market reforms. Like healthcare's gotten too big. And there's very little evidence that big healthcare has led to anything better for patients.
Little evidence. There's zero evidence.
I was just being nice. I was just being nice.
Outcomes have gotten worse.
I was just being nice. So I really think, and I also think it's at the heart of the burnout problem. I think when you take these organizations that were small and intimate and personal, and you fold them up into something really big and make people feel really, really small in the context of something really, really big, you get where you are today.
Just to kind of close with some more positive conversation, are there organizations that you really admire other than your own, which I hope you do? They're just like organizations who are like, all right, they're going to be part of the big reset because they get it.
There's some leaders out there who I think are really saying more of the right things and fewer of the wrong things. And I think hopefully are doing more of the right things and fewer of the wrong things. Like I worked in the Obama administration, but I'm actually very excited about Marty Makary as the FDA commissioner. I think he brings a common sense view of a lot of problems. And I think
love his book.
Will hopefully be a breath of fresh air for, the federal healthcare policy making universe. I think that there's places like Northwell Health, which I think have demonstrated the art of the possible outside of traditional academic settings, almost reinventing a class of organization, I think, point a way to the future. But again, I think part of what needs to happen is the game needs to change a little bit more. We need to make it much more about like being better than being bigger. And that's really what I'm hoping to see in the next couple of years.
Yeah.
So,
and the question I like to ask all of our guests, if you could wave a magic wand and change one thing about healthcare instantly, what would it be?
it's just thinking much longer term. This single year thing that we are focused on is just out of control. And so I would love that. The other thing I will just say is, like, I'll give myself the privilege of a second, is like data interoperability. We have to just get out of this view of like health data being like guarded more tightly than credit data or personal finance data. And then the last thing, I'll just give you a third one, is we need a common, in the spirit of the Department of Government Efficiency, we need a common front door across all government agencies. Like, everyone's a client of the government. And like, unfortunately, I had the experience last year of reporting my father as having passed, and the federal government decided that I was dead instead of my father, in addition to my father. And then the effort of unraveling this,
You're
Hallie,
like,
was,
no, I'm still here.
Yeah, I don't know. But unraveling it once I unraveled it with the, Social Security Administration, then I had to separately unravel it with the credit bureaus, and I had to separately unravel it with the IRS. And I wasn't able to pay taxes last year. So the interesting thing that it opened up for me was like the idea that everyone is a client of the U.S. government, whether you're Medicare or Social Security,
taxpayer,
maybe you're a HUD taxpayer.
Yeah.
Like, we make it very complicated to interact. But by the way, I was still able to fly. My wife reminds me I was still able to fly. I was able to go on TSA and as a dead person. And so there was clearly no interchange.
That wasn't connected. Yeah, somehow that wasn't connected. That's crazy. It wasn't connected.
Wow.
Sorry you had to deal with that. That sounds like a bureaucratic nightmare.
It was. But that's what I hope we get to fix in the next couple of years.
Yeah.
So,
well, amen to that. Yeah. Sachin, thank you so much for being here.
Thanks for having me. Appreciate it.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.